Good evening, and welcome to our first Doctors on Call program this season. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School on the Duluth Regional Campus. I am your host for our program tonight on heart problems and high blood pressure. Again this season, we will also be hosting spots with community physicians from Essentia Health, St. Luke's Community Memorial Hospital in Cloquet, Fairview Mesaba Clinic in Hibbing, and faculty from the medical school. The success of this program is very, very dependent on you, the viewer. Please call in your questions tonight on the diagnosis and treatment of heart problems and high blood pressure. We will do our best to address them. The telephone numbers for your questions can be found at the bottom of the screen. Our panelists this evening include Dr. Kimberly Boddicker, a cardiologist with the Essentia Health in Duluth, Dr. Ken Ripp, a family medicine physician with the Raiter Clinic in Cloquet, and Dr. Arne Vainio, a family medicine physician with Minowayan Clinic on the Fond du Lac Reservation. Our medical students answering the phones tonight are Thias Boyd of Eudora, Kansas, Michaela Lassard of Grand Rapids, Minnesota, and Molly Vale of Elk River, Minnesota. And now on to tonight's program on heart problems and high blood pressure, and season 39 of Doctors on Call.
Wow.
Dr. Vainio, I think I'd like to start with you. In your clinic, you do primary care and general family medicine. What kind of heart or blood pressure problems are you seeing? What do you think is the most common?
Buju gete nishnabeg, niden nishnabidug. Ogamaben is indigo jibwimung, Missy Zaga, Igning Nina Dunjaba, Onigamin Singanda. I'm Dr. Vainio. I work on the Fond du Lac Reservation, and I've been there for 22 years. And when we do something important, our elders tell us it's important to use our language, and that's why I did that. But problems that we see primarily, we see a lot of diabetes. With diabetes comes hypertension and heart problems. We see congestive heart failure. We have extremely high rates of tobacco use. I'm a proponent of non-traditional tobacco use is what I say. The tobacco used for ceremonies, I don't really count as bad. And it's when people are chain smoking those things that they really cause problems. And like I said, we have extremely high rates of smoking. In the neighborhood of 59% of our adults smoke. And we have programs working on trying to get people to quit, to cut back. Vaping isn't the answer. And so high blood pressure is the thing that we see a lot of. In medical school, there's a saying, if you know diabetes, you know medicine, and we see a lot of diabetes. So we see pretty much the gamut of everything. We refer patients to cardiology. We do a lot of primary cardiology care. And I also work in the community and know Dr. Ripp pretty well from being in Cloquet.
Dr. Ripp, maybe you could tell us a little bit about your practice and the types of patients you see with cardiovascular and blood pressure problems.
So I, like Arne, I'm a family doc, so we see everyone from little kids up to adults. And the primary, the hypertension practice that we see is mostly adults, but we do see occasionally have a teenager who will develop it young, and we follow those people all the way through adulthood. Primarily we see it as people get older. By the age of 65, about 70% of people have high blood pressure, even people who are, look like they shouldn't have it. So a lot of times we just have to convince people that this is part of what happens to people as they get older. This is what happens, and most important thing is trying to teach them, saying there's lifestyle changes. When lifestyle changes fail, medications help, and the whole idea is let's prevent them from needing to meet with the cardiologist, trying to prevent the heart disease, prevent the strokes, prevent the kidney disease, prevent the bad outcomes. So it's an opportunity to prevent, hopefully, something worse down the road.
Dr. Boddicker, your practice, do you want to tell us a little bit about that? Because you're on the receiving end, probably from all of us at one time or another.
Well, I mean, generally speaking, as they mentioned, we see the patients that kind of make it past the front line. So unfortunately, we see those who despite medications or lifestyle changes, have some a result from their disease processes, specifically coronary disease, heart failure, heart rhythm problems. And you know, we're here to help support primary care and trying to deal with those problems and various treatments.
We might as well jump right into questions. And we kind of chatted about some of these a little bit earlier, but the first one's about cholesterol and about what are our opinions on statins. So I think, first of all, what's the latest feelings on cholesterol and treatment? And then let's chat a little bit about statin drugs. So one of you primary care guys want to take a shot at that?
Sure. So statins is a family of medicines that have been really, I think, game-changing for the cardiovascular disease. It's the first really truly effective medicine we had to lower someone's cholesterol significantly. Not only did it lower cholesterol, and that's just a number, it changed the outcome, meaning that people who took statins did better. They had less recurrence of heart attacks, less admissions to the hospital, so it was less second strokes. And so for us, it was a great drug to help keep people out of the hospital. Does everyone tolerate it? No. And so sometimes it takes some effort. Sometimes the first statin you start with, people don't tolerate, and you have to move through a couple of statins to find one that works. And any statin that you can be on, even if it's low dose, is better than not being on one. The reduction in risk that you get, or the benefit you get, cannot be explained by just the change in the number. It does other things to the body that helps protect the heart.
So is the number still important? Or is it just better that diabetics and people with heart disease just go on statins?
If you can get to the goal, great.
Arne?
If you can't, then get as close as you can with the statin, I think.
Well, I would agree with Dr. Ripp completely. We have, you know, with diabetes, we really push to try to get cholesterol numbers down. When blood sugars go up, lipid numbers, cholesterol numbers tend to go with it. And so controlling, you know, nobody's just the lipids in a bucket. And so all of that stuff is connected. And when somebody's hemoglobin A1C is really high, and people with diabetes will know what that number is. You know, the normal is less than 6.5. Out of control is over 10. The highest we can measure is 14. And we see people with 14 on their hemoglobin A1C. And when somebody's sugars are that high, when they're in the 400s all the time with their sugars, then their cholesterol numbers tend to go up with that. And controlling all of that together is important. And but you know, we do see benefits with statins.
Kim, from a cardiologist standpoint, thoughts?
I guess I would say that, you know, the American Heart Association has a saying, know your numbers. That's how you prevent coronary disease, and that means know your blood pressure numbers, know your cholesterol numbers, know your diabetes numbers. You don't know that unless you go to the doctor, but that's how you prevent coronary disease. Our opinion on what the right number is for cholesterol has sort of changed over the last couple years. We went from being very regimented in checking it to just giving high-dose medicines, and now most recently we swung back to those people who are at high risk, which are people who've had coronary disease, diabetics, people who've had stroke, that our goal LDL or bad cholesterol is to be 70 or less, and so we target our treatments to meet that goal.
I want to go back. Another thing that Dr. Vainio, I believe, talked about a little earlier was, as you get older, one of you two did, about blood pressure going up. So blood pressure, where should we be with blood pressure these days? And maybe I'll let you take a shot at that, because it really falls into your...
Yeah. So, I mean, there's been a lot of data coming out, controversy. You know, we know that as we get older, you're at more risk for heart disease and stroke, but also you're more at risk of side effects from the medications to treat blood pressure. And our thought process is that perhaps after a certain age, 75, 80 and upwards, that perhaps treating to a strict blood pressure goal is not as safe. And actually for a while raised our blood pressure goal, the top number to 150 and the bottom number to 90, but now we've also known since doing that that increases your risk of stroke and heart attack and heart failure symptoms. So from our standpoint, we kind of focus in, the people I see in my practice generally have other risk factors like heart disease, like stroke, like kidney disease. And so generally speaking for those patients, our goal is to have a top number or systolic blood pressure of 130 with a diastolic blood pressure at 80. Obviously for the general population, if we're just treating hypertension or high blood pressure on its own, sometimes raising that number a little bit. And just like any treatment, you have to guide it to the patient. So some patients, you know, you don't want the cure to be worse than the disease, and so you always have to tailor it to what works for the patient.
There's been a couple of questions that have come in with high blood pressure. How does this affect the kidneys? And Arne, you and I had talked about it a little bit earlier. Do you want to start down that path and talk about it a little bit?
So high blood pressure it damages everything. So high blood pressure is called the silent killer, and it's always been called that because people generally don't have symptoms. And when your blood pressure runs high, you know, if you don't know your numbers, then you're at risk for kidney disease, heart disease itself, strokes, ischemic heart disease, which means not getting enough oxygen to the heart. But your kidneys, blood pressure and the regulation of blood pressure is actually pretty complicated. And it has to do with your kidneys and a thing called angiotensinogen and angiotensin converting enzyme. And so some of the medicines that we use work on that system, but people that get high blood pressure can get kidney disease, and chronic kidney disease is a thing that in and of itself is needs to be taken care of and needs to be followed. So I don't know if that was really a good answer or not. But
That's good. So here's the best question that's come in, and you can all enter in on this one.
So
What is the best way to lower blood pressure without medication?
So well, weight loss, exercise, diet.
smoking, quitting smoking,
Excellent, yeah.
Alcohol moderation.
alcohol moderation, yep.
There's
Low
no
sodium in
yeah,
your
low
diet.
sodium. Yep. So there's not a it's what you've been told for a long time from your doctor.
So then this comment is eating salted potato chips bad for high blood pressure?
If you are salt sensitive, it is. There's a certain percentage of the population that are salt sensitive, and if they have salt in their diet, their blood pressure is going up.
How do I know that?
You don't unless, I mean, and you can tell because if you want to do the experiment, go on a low salt diet. If your blood pressure goes crashing down, then great. If it doesn't change at all and your salt intake doesn't impact it, you might not be salt sensitive. And they've done the experiments on nursing home patients because you can sort of control their diet. And they found that a certain percentage of them are salt sensitive, but many of them are not salt sensitive. Now, if you have heart failure or you have other disease processes, then salt, for other reasons, can be bad for you because it retains fluids, makes your swelling worse.
Is sea salt better?
Not necessarily, because sea salt comes from the sea, and in the sea can be a lot of impurities. So you can.
It's still salt.
It's
Salt
still
is salt.
Yep.
Salt is salt.
Salt is salt. It
sea-
doesn't matter what kind it is.
Yes, but sea salt can have other stuff in it that's not good. So good old iodized Morton salt is fine by me.
Kim, a woman calls in with high blood pressure and experiences heavy arms in the morning. Is the high blood pressure causing it? I don't have an age. I have nothing more than that.
Heavy arms in the morning.
In the morning. Could this
And-
be from the blood pressure medicine, or what else would you think we should think about?
Well, I guess to give a good answer, I probably need more information, but in general, people can have symptoms from high blood pressure. Most people's blood pressure are higher in the early morning. That's why a lot of people have heart attacks in the early morning, because our natural cortisol levels and adrenaline levels are high when we're sleeping in the very early morning hours. And if you take blood pressure medicines and you take them in the morning, generally speaking, by the time you wake up, those medications have already worn off for the day, so before you've taken it. So, it very well could be. Obviously, when we hear people who have arm heaviness, we have to worry about whether that could be a coronary problem or what we call angina. And certainly if that's a symptom that you have and you have risk factors for heart disease, or specifically if you have that symptom at other times, particularly with activity, I would say that that's probably something that needs to be checked out by your doctor.
The reason I fielded that question to you was because the person was female, and there is a difference a lot of times from the traditional feeling of this is what angina or heart disease is, all from the boys, and with women it is different.
Right. So everybody kind of has a difference. Typically, when we think of angina, which is discomfort in the chest region or related to poor blood flow to the heart muscle, we usually think about crushing chest pain. That's, but we know not even men, but particularly women, not always have crushing chest pain, arm discomfort. I have little old ladies that typically say their teeth hurt when they walk upstairs and they go to the dentist, but it's really not their teeth, it's angina, and it all has to do with how the pain receptors feed back to the brain. It's sort of difficult to explain, but I think any kind of discomfort from this area with heart failure, risk factors for heart disease, particularly if they're getting worse, or if you're just concerned that it's a cardiac problem. I think particularly in women, those symptoms kind of get poo-pooed, or women themselves have a tendency to just blow them off to something else, that you should get it checked out.
Anything you guys want to add?
No, sometimes symptoms can be really vague, and there's a lot of things that can cause some of those symptoms, and sometimes it takes a few visits to sort through things, and sometimes you do have to get stress tests or echocardiograms or things to look at somebody's heart to make sure it isn't that. When
yeah, and I agree. I mean, it may not even be heart related, but I mean that's the one thing that you don't want to miss. And just a lot of times your doctor, just by talking to you and listening to your story, can tease some of that out. And there's lots of ways we can work through that without doing invasive procedures and stuff to sort that out.
I don't want to continue taking my lovastatin because of side effects. Is there a similar medication I can take? And you kind of touched on that before, so maybe you want to go down that road, or either one of you can do
I
that.
think it was Dr. Ripp that talked on it, but
Was that? That's right.
Yeah, so lovastatin is one of the older statins. Nothing wrong with it, but if it's not the right statin for you, I would say that you want to try the other statins because they are metabolized differently, and sometimes you can get benefit at a low dose from a different statin. Lovastatin is not the most potent statin, so I would say time to make a change. As Dr. Boddicker said, we want people to feel well on their medications. Just with the high blood pressure medicines, I explain to my patients that I want them to have their blood pressure down, have the cost be reasonable, and have them feel no worse, if not better, when they take it. And with this statin, I mean, it's going to be hard to convince someone to take this pill that they know makes them feel bad every day. So it's time to look for something different.
Correct. Yep, I agree. What is the best time of the day to take blood pressure medicine? This one's a valsartan.
Ooh, night. Actually, so the data is for the ACEs and the ARBs. They're asking us to try and dose those in the evening for those two classes of blood pressure medicines. And as Dr. Boddicker said, we see this rise in the blood pressure in the morning hours, and that's when we see our heart attacks, our cortisol surge. And so the idea is to take those, at least those two medicines are recommended at night to prevent that surge a little bit, hopefully protecting a little bit better.
Arne, what's the ideal blood pressure for a 70-year-old man?
I guess I don't know the exact answer. Ideal blood pressure, according to the American Heart Association, is less than 120 for the systolic or the top number, and less than 80 for the bottom number. So elevated blood pressure starts, you still don't get to go up on your bottom number, so the bottom number is still 80, and the top number for elevated blood pressure is 120 to 129, and then when you start getting up into 130 to 139, and then the 80 starts climbing into 80 to 89, then you're in kind of the stage 1 hypertension area, and then stage 2 hypertension, and in that, sometimes people can lose weight, they can exercise, they can watch their diet. Again, 70, I guess it depends. There are young 70-year-olds, and I see 40-year-olds that are 80. And so it just depends on what somebody's like. And then if somebody there's a hypertensive crisis or urgency when people go over 180 on the top number and over 120 on the bottom number, and generally that needs to be treated right away. I mean, somebody could, the aneurysms. There's a whole bunch of stuff that can come with that. Strokes, ischemic heart disease.
With some of the elders, I also have gone to taking the blood pressure when they're standing, because sometimes the blood pressures, they just can't hold the blood pressure, and you have a nice blood pressure when they're sitting, but they're dizzy all the time. And once in a while that gets to be a factor too. sweating and facial flushing so sweating and is facial flushing related to high blood pressure, and does blood pressure go up after eating? Yeah.
So the blood pressure, it depends upon what you're eating.
That's right.
But usually the blood pressure will dip a little bit after you because the blood is going to your gut to absorb the food and do that work. And so that's why after Thanksgiving meal, you want to lay down and take a nap. And so your blood pressure does dip. Now the flushing is, you really have to sit down and talk to your doctor. When does it flush? Why does it flush? Now, if every time you eat spicy food it flushes, that's probably not your blood pressure. But, certain blood pressure medicines might put you at risk for flushing. But in general, I wouldn't say, if you're flushing a lot, you have high blood pressure.
A lot of these things are things to talk to your primary care doctor about.
Yes.
Mm-hmm.
Can chest pain be a symptom of atrial fibrillation?
Yes.
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 So what is atrial fibrillation? Kim, do you want to do that one? We'll pass it
Sure.
off to you.
Well, atrial fibrillation is a very common, probably one of the most common irregular heart rhythms that we see, where the top part of the heart becomes disorganized and makes the bottom part of the heart go usually fast, not always, but usually fast and irregular. It's not necessarily life-threatening, although it can cause a lot of symptoms and anxiety in patients that make them feel like it's life-threatening, but you can have a lot of different symptoms from that. Chest pain, fatigue, short of breath, lightheadedness, palpitations, or what we call skipped fast beats. There's other people who have no clue that they have atrial fibrillation at all. But it is very possible that somebody could have chest discomfort from atrial fibrillation. We worry about atrial fibrillation for two reasons, even though it's not necessarily life-threatening, but if people have symptoms from that, we want to make sure that their heart rate is nice and controlled and then discuss various options for treatment to control it. But it also can increase your risk of stroke in certain patients. So it's very important that if you have atrial fibrillation, you talk to your doctor or a cardiologist about what is your risk for stroke and then how are ways that we can prevent stroke.
Ken from Cloquet. I am a post-myocardial infarction person. How do I go about getting back into an exercise program while being a diabetic and overweight?
So usually after a heart attack, the goal is that in the hospital soon after the heart attack is they get you into early cardiac rehab, and that usually continues as an outpatient, and that can go on for months. And then a good cardiac rehab program, and there are plenty in the area, Cloquet has them, Duluth has them, would be to guide that person from monitored training to a home program. They say, okay, these are the exercises you should be doing every day, and hopefully transforming them. Some people who, as I say, get the bug and say, boy, I need to do this and I can do this, can transform themselves with regular exercise and really reform their body. Heart disease is one of the diseases that we have changed. We have great drugs to help prevent it. If people have a heart attack, we have drugs that can open the arteries and stents that we can put in and help prevent damage and allow people to make it through this period and go on for a long life afterwards.
Kim, a fast question, but one that's going to take a little bit. Signs and symptoms for replacement of a faulty mitral valve.
Signs.
Got about a minute or two to do that.
Like how the type
That's all
of
I got.
signs and
What
symptoms
kind
of
of things would you think of when you'd want to have it done?
Usually it depends on what kind of the valve is, but the most common would be something where the valve is leaky or the blood's moving backwards instead of forwards. They're the same kind of symptoms that people get when they have, quote, heart failure. Doesn't mean your heart is failing, but the blood flow or circulating through the heart's going the wrong direction. So shortness of breath, what we call decreased exercise tolerance, which is kind of a vague symptom, but meaning I can't do what I used to, meaning a month ago, not 10 years ago. So getting worn out more easily. Problems breathing at night, perhaps swelling up with fluid. Those are the most common symptoms.
Is there a medication besides metoprolol to treat palpitations? Metoprolol makes me dizzy.
Calcium channel blockers could work for that, so that's a thing that can control rate. And then when a heart rate starts going fast, like in atrial fibrillation, so what happens with atrial fibrillation is the top part of the heart, normally the top part squeezes, it fills the bottom part, and it's just this ballet of this perfect timing. There's two sides to the heart. But what happens with atrial fibrillation is the top part is just doing this. It's like a bowl full of Jell-O, and then And then some of those impulses get through, and then the heart rate, the bottom part, just beats whenever it feels like it, and it starts going fast usually. And when a heart rate starts going fast, that blood is thicker than water, and it can't fill, and that causes a lot of the problems that come with that.
Why does your blood pressure go up in the evening after dinner? 30 seconds. We just got done talking about it went down.
I will say, I mean, I'm not sure why it's going up for that person. If they may have a short-acting medicine, might be wearing off then.
Probably.
But it does. One thing is where the data is showing that ambulatory or home blood pressure readings are really critical to help us monitor. We get one little brief snapshot in the office, and it is nice if the patient, if you ask the patient, do you check at home? They say yes, and here are my readings. Boy, that is a lot of good data for us to look at. So.
I want to thank our panelists this evening, Dr. Kimberly Boddicker, Dr. Ken Ripp, and Dr. Arne Vainio, and our medical student phone volunteers, Thias Boyd, Michaela Lassard, Molly Vale. Please join Dr. Amanda McDonald next week for a program on opioid reduction medical assisted therapy, when her panelists will be Dr. Joe Bianco, Dr. Timothy Kafal, and Dr. Lisa Prusak. Thank you for watching, and have a great night.